Dear doctors, in this video I am going to discuss questions related to EDIC Part 1. In this video, I will be discussing questions related to different drugs used in critical care setting. So let's start.
Question 1. A 62-year-old patient with septic shock is on norepinephrine. Which physiological effect best explains its benefit on mean arterial pressure with minimal increase in heart rate? Pure alpha-1 mediated arterial vasoconstriction. B. Alpha-1 mediated venoconstriction increasing stressed volume. C. Beta-1 mediated increase in stroke volume with reflex bradycardia. D. Preferential constriction of efferent arterioles. E. Dopamine receptor mediated renal vasodilation. Correct answer is B. Explanation. Norepinephrine primarily increases mean arterial pressure by alpha-1 mediated venoconstriction, which increases stressed volume and venous return, improving cardiac output without significant tachycardia. Reflex bradycardia counterbalances beta-1 effects. Renal dopamine effects are not relevant. Question 2. In prolonged septic shock, vasopressin is added to norepinephrine. What is the primary rationale? Stronger arterial vasoconstriction than norepinephrine. B. Prevention of catecholamine-induced arrhythmias. C. Restoration of vascular tone via non-adrenergic pathways. D. Improved renal perfusion via V2 receptors. E. Increased cardiac contractility. Correct answer is C. Restoration of vascular tone via non-adrenergic pathways. Explanation. In prolonged septic shock, the primary rationale for adding vasopressin to norepinephrine is to restore vascular tone using a non-adrenergic mechanism, activating V1A receptors rather than adrenergic receptors. This is critical because patients in prolonged shock often develop relative vasopressin deficiency, and sepsis causes downregulation of alpha-adrenergic receptors, leading less responsive to catecholamines like norepinephrine. By using a different pathway, vasopressin allows for a catecholamine-sparing effect, reducing the high doses of norepinephrine that are linked to organ toxicity and poor outcomes. Vasopressin does not improve renal perfusion and has no inotropic effect. Question 3. Why does propofol cause more profound hypotension in septic patients? Direct myocardial depression. B. Increased cerebral blood flow. C. Reduction in sympathetic tone and venodilation. D. Histamine release. Inhibition of baroreceptor reflex. Correct answer is C. Reduction in sympathetic tone and venodilation. Explanation. Propofol causes systemic vasodilation and venodilation, reducing preload and systemic vascular resistance. Septic patients already have vasoplegia, so hypotension is exaggerated. Myocardial depression is minimal at clinical doses. Question 4. Why is cisatracurium preferred over atracurium in critically ill patients? A. Faster onset. B. Longer duration. C. Less histamine release. D. Renal excretion. E. Hepatic metabolism. Correct answer is C. Less histamine release. Explanation. Cisatracurium is often preferred over its parent drug, atracurium, in critically ill patients primarily because it lacks the histamine release associated with atracurium. In the high-stress environment of an intensive care unit, avoiding histamine-mediated side effects such as hypotension, tachycardia, and bronchospasm is crucial for maintaining hemodynamic stability. Additionally, cisatracurium is more potent, which means lower doses are needed, leading to significantly lower levels of laudanosine, a potentially neurotoxic metabolite, compared to atracurium. Both drugs undergo Hofmann elimination, making them ideal for patients with renal or hepatic failure. Question 5. Which antibiotic exhibits concentration-dependent killing and requires high peak levels in sepsis? Piperacillin, tazobactam. B. Meropenem. C. Linezolid. D. Vancomycin. E. Amikacin. Correct answer is E. Amikacin. Explanation. Amikacin exhibits concentration-dependent killing, meaning its bactericidal activity increases as the peak plasma concentration relative to the minimum inhibitory concentration increases. In the context of sepsis, high peak levels, often 8 to 10 times the minimum inhibitory concentration, are required to maximize bacterial killing and utilize the post-antibiotic effect. Aminoglycosides, including amikacin, are frequently used as part of empiric therapy in severe sepsis or septic shock due to these properties. Piperacillin, tazobactam, meropenem, and linezolid are time-dependent antibiotics. Vancomycin is concentration-dependent, but specifically associated with AUC to minimum inhibitory concentration ratio, not just high peaks. High peak concentrations of aminoglycosides improve efficacy, while trough levels correlate with toxicity. Question 6. Which factor most strongly predicts vancomycin-associated nephrotoxicity? Total daily dose. B. Duration of therapy. C. Trough concentration greater than 20 mg per liter. D. Continuous infusion. E. Patient age. Correct answer is C. Trough concentration greater than 20 mg per liter. Explanation. While several factors contribute to vancomycin-associated nephrotoxicity, elevated trough concentrations, specifically those exceeding 20 mg per liter, have consistently been identified as the strongest independent predictor of acute kidney injury in clinical studies and meta-analyses. Research indicates a direct correlation between rising trough levels and the incidence of toxicity. Patients with troughs greater than 15 mg per liter have a threefold increased risk, and this risk climbs significantly as levels exceed 20 mg per liter. Continuous infusion may actually reduce toxicity when appropriately monitored. Current guidelines emphasize monitoring troughs, or more recently, AUC, specifically because they are the most reliable markers for managing the risk of renal damage. Question 7. In septic shock, hydrocortisone improves shock reversal primarily by increasing cardiac output. B. Enhancing alpha-adrenergic receptor sensitivity. C. Reducing cytokine storm. D. Improving renal perfusion. Direct vasoconstriction. Correct answer is B. Enhancing alpha-adrenergic receptor sensitivity. Explanation. Hydrocortisone is used in septic shock primarily because it helps reverse shock by increasing the sensitivity of the vascular system to catecholamines. Means it restores vascular responsiveness to catecholamines. In septic shock, patients often experience vascular hyporesponsiveness, where their blood vessels stop responding effectively to the body's own or administered vasopressors. Hydrocortisone restores the density and sensitivity of alpha-adrenergic receptors and improving signal transduction, which facilitates vasoconstriction and allows for faster withdrawal of vasopressor support.
Dear doctors, here I finish. If you have any question, problem or confusion, please write down in comment section where I will respond. See you in my next video. Till then, bye and take care.